What if I told you there's an illness that more than 1 in 6 people in England experience every week, and that people with serious cases die, on average, up to nearly 20 years earlier than healthy people?
My name's Jeanette Murray. 20 years ago, I had a young daughter. Well, she was 2.5. And we lived with my dad up until she was 1, and then we got our own place. And I took food up for him, and I found him dead on his floor in the kitchen. And it just frazzled my brain. It just really, really broke me as a person. I didn't know how to cope. I didn't know what to do.
I'm talking about mental illness. Our mental health is connected to our physical health. Having a chronic condition can cause depression or anxiety, and having a mental illness can lead to poor physical health. Mental health conditions are incredibly common. They can be temporary or chronic, and they can be related to a traumatic event, as Jeanette experienced.
It tipped me over the edge. I took a couple of overdoses, and I ended up in mental health services. I was in an inpatient in a couple of the wards, but I didn't know how to kind of express myself. I think I was in pure shock because I was only 49 years of age. That's no age at all. Because I was mentally ill, social services were involved, and they kind of wanted me to sign my parental responsibility over to them so they could get someone stable basically to look after my daughter. I was terrified of losing my child, to be fair, and I got discharged off the ward, and I came home. I sat on my bed for quite a few days, weeks maybe, on my own, getting inside my own head, trying to figure out what I could do better that would enable me to get my child back. And within a couple of weeks, I got her back. She was home. I kind of like pulled my socks up above my head. I'd say that they're still up now because I've never had no more admissions or anything since I pulled my socks up, and that was to get my child back.
I am science communicator, actor and Liverpudlian Stephen McGann, and this is AI and Us, The Future in Our Hands, a series exploring how artificial intelligence, or AI, is changing the fabric of our world, with Liverpool leading the charge to understand and harness its power. In this episode, we'll be exploring how AI can improve mental health care. This is Dan Joyce, a consultant psychiatrist who works at Liverpool's Mental Health Research for Innovation Centre, or M-RIC for short.
Most of my work is focused on using data science, which includes things like AI, to try and solve problems that crop up in clinical psychiatry, so in the treatment of people with mental illness. One tragedy is that still in 2025, if you have a severe and enduring mental illness, your life expectancy is on average between 10 and 20 years shorter than someone who doesn't have a mental illness. When you add to that factors like where you live in the country and the overall level of disadvantage in the region you live in, that problem gets bigger. I think that's one of the reasons we get really excited by trying to solve this problem. So that's one of the imperatives that drives us, particularly in M-RIC, to try and solve these problems by collaborating with all the folks that will become our patients or are our patients, and trying to understand from their point of view what we could do differently or better to try and reduce that differential in life expectancy. It isn't just about life expectancy, it's also about quality of healthy life. How many years can you live in a state of good well-being?
Now, mental health services across the UK are strained. Mind UK's big mental health report of 2024 found that in England, the cost of poor mental health is £300 billion a year, and over 2 million people are on waiting lists for NHS mental health support. Dr. Joyce thinks AI can help with that.
A really big problem. Very often, patients are referred into a generic single point of access for mental health care for a whole host of quite complex systems and cultural reasons. Those referrals get send from one team to another to another. Now, that's a job that humans have to do, opening up a patient's medical record and sitting and reading it and then making a decision. What we know from the research on those processes is they're quite capricious. So the decision to refer a patient on to another team are often not always that clear. If you referred two very similar patients to the same team, you may not get the same answer. We've looked at using so-called large language models to try and find ways of improving system efficiency problems in the NHS. Most people will be familiar with these in terms of things like ChatGPT. You could use these language models to help decide whether or not a patient has been referred to an appropriate clinical service or whether or not they'd be better suited to a different service. So we were trying to solve a system efficiency problem. You can make headway using AI in an application. A human can reasonably check what's going on, so you can rely on the AI to do something quicker, perhaps more efficiently and perhaps with a bit more attention to detail.
This is precisely the kind of thing that AI could be really great at. Repetitive tasks that require ingesting large amounts of information quickly and consistently, without losing focus. But Dr. Joyce and his colleagues are also looking at something much more ambitious, something that really could change the way mental health services are run.
A large emphasis of the work that we do in M-RIC is on using data and using technologies proactively to help patients and to help clinicians and patients work together more effectively. And a big component of that we call the mental health avatar, the digital representation of a physical thing in the real world that gets near real-time data. You can then experiment with it. You can then ask questions of it. You can simulate things with it. When you have a mental illness, some mental illnesses are relapsing and remitting. So you'll have a period where you'll be well. There may be some stimulus or something happening in your life or in your community or society more widely that destabilizes you and you become unwell again. For that reason, patients often tell us they have to keep repeating the same story over and over and over again.
Every time I used to visit the GP surgery, I had to tell my story over and over again, and then it triggered me. So it was like bringing triggers and then the flashbacks of the past and different things. It wasn't a really good place to be in, to be fair, but to have the digital technology, what we've got nowadays, you wouldn't have had to have repeated yourself every time.
To try and assist both patients and clinicians to have the best available data, we're working on the avatar. We'd like the avatar not just to be the sort of sum of information available over the last 2 weeks or 3 weeks, but we'd also like information that triangulates with existing medical records. Anyone who's worked in the NHS will tell you that that's an incredibly challenging problem. You can't easily get between different medical record systems, and we'd like that to be available to both the patient and the clinician in a consenting way so that the patient retains control over that consent process. When we see a patient face-to-face, that golden time we have in clinic, we can use that more effectively and not spend time rereading existing sets of notes, which, again, very often don't contain or capture the detail that's relevant to the patient.
Information from your GP surgery from the hospital, from your psychiatrist, psychologist, all that information is all going to be in just one place. So nobody will have to be going searching through different parts of the system to find out exactly what's up with you or where you've come from.
And the idea is there'll be a component where the patient interacts with their own avatar in order to increase the amount of data that's available so that when they see a clinician, the patient can work with the clinician to try and understand what's going on. And that might be, for example, a couple of weeks of information about how that person's symptoms have changed or what's provoked them starting to feel less and less well.
And the avatar itself would be linked to your mental health services or even your GP surgery.
So for the digital twin to be linked up to the necessary places, the GP can see it, the psychiatrist can see it, the psychologist can see it. They would know what mood or what your mode was, like up or down. And I think that helps before a person goes flat, like on the floor. You can see what's happening to you before you hit rock bottom.
It's a fascinating idea, because actually reaching out for help when you're already feeling anxious or low can be intimidating. But this could mean that people who are struggling are able to get help sooner.
And at the same time, the idea with the avatar is it can help triangulate different sources of information. Most of us will be familiar with the array of health technology devices. A great example of that is rings or devices that they can put on their wrist that monitor their activity. If you're, for example, asking how active they've been or how their sleep has been for the last couple of weeks, at best you're getting a patient to do some sort of mental averaging of their experiences over time, which is not really that helpful when instead we could ask for the patient's consent and they could gift us with permission for looking at their activity. Although we can't lean on those devices to be medical quality data, if patients are giving us consent to give that data to their avatar, that gives us another way of triangulating information without having to ask people to constantly recall or record information so that it's available. So you can take data from a patient and they become their own model. So you know how the patient is at a certain time point. You can use the same data capture or data collection and sensing technologies, whatever it might be. And what you're doing is you're comparing the patient with themselves at a previous time in their history. So that has real utility as far as I can see, because you're able to look at how the patient is changing or how their symptoms are changing over time. And you only really need that patient's data to do that.
The Mental Health Avatar. It's a project that holds real hope in the future for making patients' path to recovery easier. Now, considering the costs of mental health care to the NHS, it could really make a difference.
My feelings are, if that digital twin was available like 18 years ago, I wouldn't have took so long to get well. I think it would have helped massive.
These days, Jeanette is actually working with M-RIC to develop the mental health avatar.
Before I got into this kind of work, I was volunteering on the mental health wards. I was going back to give patients hope that they can get well. It's not easy to get well, but it's a better life than just being on the ward. There's more to life than that. So since being involved with M-RIC, it's the first time that us people with lived experience have been listened to. We've always felt like it's them and us. The thing about M-RIC is they're pulling in people with lived experience so the people with lived experience can help.
But of course, there are barriers to ensuring that artificial intelligence works for the patients and not against them.
There are a number of obvious barriers, I think, to the use of technology in healthcare, but there are some that I think are perhaps a bit more unique or a bit more idiosyncratic with mental health care. There is a really careful balance that when you deploy that technology for a specific context, it has to be negotiated with the person that is going to be subjected to the use of that technology. You have to ask people's permission and what they think is acceptable. But it isn't a straightforward conversation. There's no one size of consent or there's no one uniform way of deploying these technology. It is very use specific. I'm not pretending that we have an answer to this, but one of the things that you certainly can do is simply put the decisions around that technology being used in the hands of the patient. And you can say to people, if you were to use this particular tool, this piece of technology, if I have access to that information, I can help you more by doing this. You're constantly saying, are we still on the same page? Are we in agreement that this has provided benefit? Because if it isn't, there's no need to continue doing it. People quite legitimately have an experience with the technology and they decide that in retrospect or on reflection, they're not comfortable with it. And I think that's really one of the important things that we try to build into our work, is to have that consent model co-produced by the patient. And part of that is the shared decision-making around when to use technology for what purpose.
Now, when my producer first told me about this episode's theme, I thought we might be hearing about AI delivering some sort of therapy, maybe through a chatbot. I have heard of people using ChatGPT prompts to deliver some sort of therapeutic insight into their lives. And there are even apps offering AI-based cognitive behavioural therapy. But you might have noticed that using AI for therapy isn't one of M-RIC's projects. I wanted to know what Dr. Joyce thought about the potential for an artificially intelligent therapist.
A really common use case that's pushed more and more in the, I'll use the term loosely, but in the mental health space, is the notion of using chatbots. So again, these are technologies that are based on large language models, wrapped in some way so that they can interact with you. And there's been, I think, a very obvious excitement that these might be able to provide some sort of talking therapy or psychological intervention. It's important for me to note that I'm not a psychologist, so I'm not super qualified to talk about the formal processes of therapy and how it proceeds and how you design a psychological intervention specifically for a person. But the excitement around chatbots as therapeutic agents in dialogue, I think, hinges on a number of assumptions that don't actually hold up very well. I think the first assumption is that what a mental health care professional does when they're talking to a patient, either in a therapeutic context or simply talking to them, is fundamentally just be nice to them. Talking to you in a nice way, an empathic way, or apparently friendly way is somehow equivalent to therapy. I would not be surprised to find my psychology colleagues finding that a difficult pill to swallow, because it does reduce what they do to fundamentally chatting to people and being nice. So I think it's a mistake to equate chatting nicely and fluently with an actual psychotherapeutic intervention. The use of chatbot technologies to have a perfectly pleasant conversation in the kind of well-being space. And that may well be a well-being intervention. It may be something that makes you feel good or answer some questions or helps you resolve some self-doubt. But as you move from talking about well-being to talking about health, and then you go from health to talking about illness, and it's my belief, if you have a severe and enduring mental illness, the technologies or the interventions that you would need for helping someone cope with that are clearly not the same as having a friendly chat with a non-specific chatbot that may or may not be providing useful information.
And it's one of the dangers of large language models, the kind of AI that has recently gone so mainstream. It appears to know what it's talking about. It seems so real.
And there's a really interesting precedent here that doesn't get as much attention as I think it probably should. But in the late 1960s, there was a chatbot called Ailsa, which simulated a Rogerian, as in Carl Rogers from the positive psychology movement. It simulated a conversation with a Rogerian psychotherapist. And it was based on a very small number of pretty straightforward rules that just learned to tease apart what you were telling the chatbot. And of course, you had to type your responses to it. It's a completely unsophisticated piece of software. It doesn't learn anything from data. It's not a large language model. But it was remarkably persuasive to the humans that used it, to the extent that its inventor, Joseph Weizenbaum, in his book on the topic here, he talks about he had an administrator who would insist on shutting the door between their offices so they could have a personal, private conversation with Ailsa. And Weizenbaum talks a lot about the dangers of trusting, algorithms that have that are actually quite straightforward, but where they superficially give the illusion of doing something quite profound. Because large language models can display an impressive, but perhaps sometimes superficial, impression that they understand and respond to language in a meaningful way. I think that's very different to the work that a skilled talking therapist would do with someone that they're working with. So it's a mistake to take what works in the well-being space and then to migrate it all the way to the other end of the spectrum where you're dealing with people struggling with a severe mental illness. So there have been examples where there's been overselling of the results for these well-being chatbots, that they have somehow prevented a serious mental illness, or that they have diagnosed a serious mental illness, or that they have prevented the unfortunate consequences of mental illness. I just think that's quite disingenuous, because a lot of this technology, instead of being driven by academic interest, is now driven by commerce. I think the direct-to-consumer oversell of some of these AI based chatbot models, where people might be persuaded that they do more than they actually do. And also, of course, there's no solid data that supports that they do something useful for people with severe and enduring mental illness.
So, an artificially intelligent robot therapist might be a sci-fi fantasy. At least humans are still useful for something. In the next episode, we'll be looking at how AI can impact housing. It's not just bricks and mortar anymore. Do join me, Stephen McGann, for the next episode of AI and Us, The Future in Our Hands. AI and Us was written and produced by Nija Dalal-Small. The executive producer was Ailsa Rochester. AI and Us was an Audio Always production made in collaboration with the University of Liverpool's Civic Data Cooperative.